Hey everyone, Ryan here. Welcome back to our pharmacology series. In this video, we're going to talk about pharmacodynamics. So we talked at length in the last video about pharmacokinetics and how the administered dose of a drug gets absorbed by the body, distributed to various fluid compartments, metabolized, usually in the liver, and finally eliminated, usually through the kidneys. The actual active dose that was left after the distribution process is what interacts with a drug target and produces an effect. And that's what we'll cover in this video on pharmacodynamics. So pharmacodynamics is all about what the drug does to the body. So almost all drug targets are proteins of some sort. So these active drug molecules will be binding to various proteins to create their effects. And these proteins can be receptors, ion channels, enzymes, or even carriers. And we'll also talk about how drugs can function in terms of their mechanism of action as agonists, antagonists, or inverse agonists. Now, we think often of the therapeutic effects of a drug, like local anesthetics providing numbness, antibiotics to fight bacteria, analgesics to provide pain relief, and that sort of thing. But almost every drug also has some sort of side effects, which can also be toxic. And we'll talk about that later in the video. So, a drug that's an agonist, what is that one doing? So it's mimicking the effect of an endogenous agonist molecule. So endogenous means it's internally or naturally occurring molecule in the body, and an agonist is inducing some sort of reaction. So the drug is mimicking that induction reaction. So a full agonist drug can produce 100% of its desired effect, whereas a partial agonist can't quite make it, cannot produce 100% of its desired effect, and it's some partial capacity of whatever that effect is. So this diagram is showing an agonist drug binding to a receptor or a protein of some sort, and it's inducing a reaction, producing an effect, and if it's a full agonist, we're getting full activation of that protein. An antagonist, on the other hand, inhibits normal function of that endogenous agonist. So now it's getting in the way of that naturally occurring induction molecule. A competitive antagonist competes with the agonist for the same binding site on the receptor. So that's shown in this diagram here. We have that agonist molecule trying to bind to the receptor, and our antagonist drug is getting in the way and inhibiting that binding. A non-competitive antagonist binds to a different non-overlapping binding site, but still prevents the binding of the agonist. So how does that work? Well, the non-competitive antagonist drug binds to some allosteric site, which changes the morphology of the cell or the protein so that it indirectly inhibits binding at that active site. And that's what I've added down here. And finally, we have the least common of these, the inverse agonist. And an inverse agonist drug inhibits the basal activity of a receptor in the absence of the normal agonist. So essentially, let's say whatever this receptor is activated normally without any agonists at all. It's just its basal everyday activity. But in the presence of this inverse agonist drug, that basal activity goes down. So they're not technically antagonists because they're not competing with an endogenous agonist. So they're in a unique category of their own, and we call them inverse agonists. So the type 1 dose response curve. This is really the bread and butter of how the body responds to the drug and how we can chart out pharmacodynamics in a visual form. The x-axis indicates the dose of the drug. The y-axis indicates the response or efficacy of that drug. And it can be either hyperbolic or sigmoid log form like we see here. And that's typically how it's represented. So the sigmoidal S-curve is what we see here, and it's a log form because the x-axis is laid out in a log scale, a logarithmic scale. So let's go over some definitions in terms of the type 1 dose-response curve. Intrinsic activity refers to the maximal effect, or Emax, of a certain drug. So that would be this peak of the curve. In this example, it also says maximal efficacy, or Emax for short. That would be this plateau of the type 1 dose-response curve. So a full agonist has an intrinsic activity of 1, or in this case, 100% response. A partial agonist is somewhere in between 0 and 1. It can't reach that 100% response that a full agonist could. So it doesn't necessarily have to be at 50% like here. It could be at 75, 25, anything in between. An antagonist has an intrinsic activity of 0. If it's doing its job as a drug, it's completely blocking binding of the endogenous agonist at that active binding site. And so the response would be at 0. And then the inverse agonist is somewhere in the negative. It's below 0 because it's blocking that basal activity. So now we're below what's even considered normal for that protein or that receptor. Some more definitions, and I've already mentioned a couple of these. Efficacy, again, is the effect of a drug as a function of binding. So that one makes sense. That's what we've been talking about up to this point. Affinity sounds similar, but it is functionally different. So it's the attractiveness of a drug to its receptor. And at first glance, that sounds synonymous. But affinity is more about the attractiveness, like think of two magnets being attracted to one another. How attractive the drug is to the protein. And this is represented by the dissociation constant, or KD. And the lower the dissociation constant, the higher the affinity of the drug. So those are inversely proportional. So the KD, again, is the dissociation constant, and it's obtained from a binding curve, which is separate from the dose-response curve we've been looking at. So KD technically is the concentration of a drug needed to occupy 50% of receptors. So similar, but distinct from efficacy and what we were looking at in the type 1 dose-response curve, but still important to know. And in terms of the board exam, unlikely to get a question, but I would just remember that it has to do with this KD value. And finally, potency. Again, all of these are somewhat similar, but they all have distinct differences. Potency refers to the power of a drug at a specific concentration. And potency is related to this value EC50, which is the effective concentration of the drug. And so EC50 indicates how much of a drug is needed to achieve 50% of the maximum response. And the more potent a drug, the smaller this EC50 value will be. And this value is directly obtained from the dose-response curve. So for example, if drug A has some effect at 500 milligrams and drug B has that same effect but only at 5 milligrams, then drug B is 100 times more potent than drug A. So we can play this out visually, how antagonists can affect a type 1 dose-response curve. So let's start with A as our starting point, and A would be our typical endogenous agonist. Now, if we add a competitive antagonist to the mix, that shifts this agonist curve to the right. So C and D would be examples of a competitive antagonist's effect. Because the competitive antagonist increases the amount of drug or agonist needed to produce the same response. So you can think of, if this is our Emax, now we need more dose. We're climbing this way on the x-axis. We need more dose to attain the same effect that we had over here. So adding a competitive antagonist drags this curve to the right, and we need more drug to produce the same response. A non-competitive antagonist shifts the agonist curve down. So because it acts differently, it decreases the maximum effect of the drug. So our non-competitive antagonist example would be curve B. And it decreases the Emax since it's acting at an allosteric site and cannot be directly overpowered at the active site. In other words, you can't just keep flooding agonist drug to overpower this. Instead, we're locked down here at in this example, probably around 40 or 50% of our Emax that we would typically have when a non-competitive antagonist is in the mix. So it's a little bit into the weeds here. If you have to just boil it down to the bare basics, just remember which direction we are shifting the curve depending on which type of antagonist we have active. All right, so that's enough about type 1. Let's talk about type 2 dose-response curves. They're also sigmoidal shaped, but they have some important distinctions. So the x-axis, we're still talking about the dose of the drug here, so nothing's changed there, but the y-axis indicates the number of subjects responding to a drug rather than the efficacy of the drug. So again, we're really talking a lot about subtle differences, and there's a subtle difference here as well, in that it considers a more holistic patient view. It allows us to look at not only the therapeutic effect of a drug, but also when it becomes toxic and even when it becomes lethal. So the type 2 dose response graph can show up with 3 separate curves, one indicating a therapeutic response here in blue, one indicating a toxic response here in green, and one indicating a lethal response here in red. So you may be asking, since the y-axis represents essentially a yes or no question, whether or not a patient responded to the drug, how do you exactly quantify that? Well, the response is some specific predetermined quantitative response, like a 30 millimeter mercury drop in systolic blood pressure, or let's say a reduction in internal body temperature at or below 98.6 degrees Fahrenheit, something that can be measured. And the doses and the responses get plotted onto these curves appropriately. So let's dive into a little bit more of the specifics. So I have 3 things in boxes here. ED50, and this is an EC50, which we were talking about with the type 1 dose response curve. This is ED50, which is the effective dose where 50% of the population responded effectively. In effect, they were treated. TD50 is the toxic dose where 50% of the population experienced toxic side effects. So you're noticing as we're climbing up, we're increasing the dose. We started with not very much therapeutic response at all. Then 50% of the population was getting treated, and we reached a really sweet spot where most of the population was responding very effectively to the drug, and it was really working. But if we increased the dose more and more and more, now we started getting toxic side effects, and this was no longer what we were shooting for, no longer desirable. And so we got to a point where now 50% of the population was experiencing toxic side effects. And maybe the other 50% were still getting some therapeutic effects, but that's really not desirable for a drug. And with animal studies, they can also measure the lethal dose. LD50 responds to the lethal dose where 50% of the population actually died. So that's if we really cranked up the dose of the drug and we got to a point where 50% of animal subjects had died with X amount of dose of the drug in their bodies. So how can we apply this on the board exam and in real life? So TI is equal to LD50 over ED50. Well, what the heck does that mean? So this is the Therapeutic Index, which is an estimate of drug safety. So we can measure that as LD50 over ED50 for animal studies. And in human studies, we don't measure LD50, so we have to use TD50 over ED50. And so that's referring to these three values of the type 2 dose response curve, whatever those doses were to get those values. So again, LD50 over ED50 for animal studies, TD50 over ED50 for humans. This is the more relevant one to remember for the board exam. So the larger the therapeutic index is, the safer the drug, because that means the dose at which 50% of the population experiences toxic side effects is a big number, because that's in the numerator, and far away from the dose at which 50% of the population is responding effectively to a certain dose, which is a much smaller number in the denominator. So the larger that number, the further these two things are apart from one another, and the safer that drug can be. So ideally, we want to administer doses of drugs that maintains the active dose somewhere on the blue curve, of course, ideally at the top of the blue curve, minimally overlapping with the bottom of the green curve. And this sweet spot is termed the therapeutic window. All right, so to summarize all of that, I apologize if it was a little bit dry and complex, but again, I tried to simplify it as much as possible. And to summarize, type 1 charts the dose versus the efficacy of the drug, more specific and a little more molecular. And type 2 charts the dose versus the response of the patient. So a bit more holistic and practical in terms of the clinical response. All right, and finally, let's talk about drug combinations. We talked about agonists and antagonists and how they can affect one another and change the curves. And now let's talk about specific drug combinations which can have various results in the body. So two drugs that are additive means that combining those drugs combines their individual degrees of effect. So this chart's showing we have some X amount of effect with A, some X amount of effect with B, and then if we're taking both of those drugs at the same time and they're both active in our body, we're getting both of their effects summed together, and so that's an additive effect. An antagonist effect, an antagonistic effect, is where combining two drugs causes a lesser effect than either one alone. So now we have A and B, and the combination of A and B active together is actually a lesser effect. And this can happen by a number of different mechanisms. Chemical antagonisms, where the drug binds directly to the other drug to put it out of commission. Receptor antagonism is competition between two drugs for a single receptor. This might sound familiar. It's what I was talking about before with competitive antagonism. Pharmacokinetic antagonism is where one drug affects the pK of another via pH. I talked about in the last video usually how two of them compete or affect one another with pharmacokinetics is in the metabolism stage. And I had a chart with various specific drug combinations. And physiologic antagonism is where two drugs produce opposing effects on the same tissue via distinct receptors. So drug A reacts with receptor A, drug B reacts with receptor B, and then they have conflicting reactions to the body. So one could increase blood pressure and one's decreasing blood pressure. Typically, that's not what we want to be happening. And lastly, we have a synergistic drug combination. And this is where combining drug A and B leads to more than the sum of the two independently. So this is A, this is B, and now both A and B together is not only the sum of the two, but we're getting an additional response. So it's basically a super version of additive. And so using two drugs that interact in this way allows you to use a lower drug dose in total. So this is really the ideal situation. If we have, let's say, two antibiotics that work really well together, we can prescribe both of them at lower doses so that we get a better effect than either one of the two if we just use them individually. Alright, so that's it for this video. Thank you so much for watching. If you're interested in supporting my channel, please check out my Patreon page if you haven't already. A huge thank you to Michael Raja, Eins Lau, David Jaden, Yanet, and all of my patrons for all their support. You can unlock extras like access to my video slides to take notes on and practice questions for the board exams. So go check that out. The link will be in the description. Thanks again for watching, everyone. I'll see you all in the next video.